Hello everyone. In this video we're going to be talking about opioid use disorder. This is the second video in the lecture series of substance use disorders. The first video was talking about alcohol use disorder and this is talking about opioid use disorder. So opioids, medications and drugs of abuse stimulate mu, kappa and delta opiate receptors, normally stimulated by endogenous opiates, and are involved in analgesia, sedation and dependence. Examples of opiates include heroin, oxycodone, codeine, dextromethorphan, morphine, methadone, and meperidine. Opiates also have effect on the dopaminergic system, which mediates their addictive and rewarding properties. Prescription opiates such as oxycodone, hydrocodone, acetaminophen, and oxycodone acetaminophen, not heroin, are the most commonly used opioids. Behaviors such as losing medication, doctor shopping, and running out of medication early should alert clinicians of possible misuse. So, alcohol opioid intoxication. What's the clinical presentation of opioid intoxication? So that is, opioid intoxication causes drowsiness, nausea, vomiting, constipation, slurred speech, constricted pupils, seizures, and respiratory depression, which may progress to coma and death in overdose. Meperidine and monoamine oxidase inhibitors taken in combination may cause the serotonin syndrome, which is composed of hypothermia, confusion, hyper or hypotension, and muscular rigidity. Treatment of opioid intoxication is to ensure adequate airway breathing and circulation. One thing you need to notice in any intoxication, in any management, you always need to ensure there's adequate airway breathing and circulation. In overdose administration of naloxone, opioid antagonists will improve respiratory depression but may cause severe withdrawal in an opioid-dependent patient. Ventilatory support may be required. So, an opioid use disorder, let's talk about the withdrawal. While it's not life-threatening, abstinence in the opioid-dependent individual leads to an unpleasant withdrawal syndrome characterized by dysphoria, insomnia, lacrimation, rhinorrhea, yawning, weakness, sweating, pilar erection, nausea, vomiting, fever, dilated pupils, abnormal cramps, arthralgia, myalgia, hypertension, tachycardia, and craving. While here it's just something like I'm just mentioning them, but they are very, very important signs and symptoms, so you need to take note of those. So, what is the pharmacological treatment of opioid use disorder? So there's medication that is methadone, buprenorphine, and naltrexone. So what's methadone? Methadone is basically a long-acting opioid receptor agonist. Then buprenorphine is a partial opioid receptor agonist, and naltrexone is a competitive opioid antagonist. And one thing you need to know about buprenorphine, it also comes in as a combination which contains buprenorphine and naloxone, and it's more commonly used because this preparation prevents intoxication from IV injection. So what's the treatment? So we got what if you have moderate symptoms, you do symptomatic treatment with clonidine for autonomic signs and symptoms of withdrawal, non-steroidal anti-inflammatory drugs, NSAIDs for pain, dicyclomine for abdominal cramps, etc. Then for severe symptoms, you need to do detox with buprenorphine or methadone. You need to monitor the degree of withdrawal with COWS, which is the Clinical Opioid Withdrawal Scale, which uses objective measures such as pulse, pupil size, tremor to assess withdrawal severity or hallucinogens. So if you want me to make a video on COWS, you can let me know and I'll make one on that. Hallucinogenic drugs of abuse include psilocybin, which is mushrooms, mescaline, peyote cactus, and lysergic acid diethylamide, LSDs. Pharmacological effects vary, but LSD is believed to act on the serotonergic system. They do not cause physical dependence or withdrawal, though users can really develop psychological dependence. Opioid intoxication effects include perceptual changes such as illusions, hallucinations, body image distortion, synesthesia, labile affect, dilated pupils, tachycardia, hypertension, hypothermia, tremors, incoordination, sweating, and palpitations. Usually last 6 to 12 hours but may last for several days. May have a bad trip that consists of marked anxiety, panic, and psychotic symptoms such as paranoia, hallucinations. Treatment: you need to monitor for dangerous behavior and reassure patient. Use benzodiazepines first line. You can use antipsychotics if necessary for agitated psychosis. In withdrawal, there is no withdrawal syndrome that's produced, but with long-term LSD use, patients may experience flashbacks later in life. So that's all about opioid use disorder, which includes intoxication, withdrawal. Thanks for watching.